Welcome, dear colleagues. I am Dr. Ashraf Radwan, Fellow of Montpellier University and the Medical Director of Maghrabi Eye Center, Medina Road, Jeddah, Kingdom of Saudi Arabia. In fact, today I would like to talk with you about the OCT, which is one of the very innovating technology and one of the tools used for our diagnosis in the retina clinic. It is one of the most important nowadays used machine for the diagnosis and the decision making in the management of a lot of retinal diseases today. In fact, the optical coherence tomography, or the OCT, it allows us to get an optical retinal scans with a very high resolution, bypassing too much that of the ultrasound. By favor of this technology, a lot of retinal pathologies have been re-evaluated, and our way of thinking for the management of a lot of diseases has been changed. OCT, it was first manufactured by Humphrey Zeiss. The first publication was done by Huang, Swanson, and Poliafito in vitro in 1991. In 1995, it was the first OCT image on a human eyes. The principles of the OCT is like the ultrasound, except that light is used instead of the ultrasonic waves. So scans near infrared light used by the OCT using 820 nanometer from a superluminescent diode are going inside the eye, making a wash for a certain part of the retina and the optic nerve. The advantage is that it gives us a 10 micrometer axial resolution versus 200 microns with ultrasound. In fact, now with the use of the spectral domain OCT, the Cirrus OCT, we can go up to 2 to 3 microns resolution. So you imagine how much you can go even up to cell in our management and our interpretation for the images of the OCT. Here is a comparison between an ultrasonic image and an image of OCT for the macula. We can see how much the macula cannot be seen clearly with the ultrasound, while with the OCT we can take a 10 micrometer resolution compared to a 200 with the ultrasound. So you can see the foveal depression as you see in the image here, and the clear image of the macula, the 6 millimeter around the fovea all around, which cannot be seen very clearly in the ultrasonic picture as we can see it, the image of the B-scan on your left side. The advantage of OCT, in fact, it is an objective document. It is non-invasive test, as we are not injecting the patient any dyes, anything. We just put the patient in front of the OCT machine that takes some images for the macula and the optic nerve. It gives us, which is the very important advantage here, is that it gives us a quantitative evaluation of the retinal thickness. So we can measure the thickness of the macula in microns, as you'll see in a lot of pictures now. It gives a third dimension to fundus examination. Much better than ultrasound and biomicroscopy, and even in a preoperative aspects. The indication of the OCT now, it is numerous, as you can see in the epimacular membranes, the macular holes, in age-related macular degeneration and subfoveal membranes, diabetic macular edema, cystoid macular edema, post-surgical like in Irvine-Guss syndrome, central retinal vein or branch vein occlusions, in the diagnosis of and follow-up of the glaucomatous patients and glaucoma suspect patients, in evaluating the optic nerve, which is one of the important tools for following these patients. Evaluation pre and post intravitreal injections, whatever anti-VEGF, triamcinolone, or before vitrectomy, and evaluating of the results of these surgical maneuvers. The interpretation of the OCT, as we see this in a normal picture of the OCT, the normal macula, compared to a specimen, a pathological specimen for the macula. As you see, it is almost very close to each other. we can see the retinal pigment epithelium and the choriocapillaris are hyper reflective, and on the upper part of it we can see the hyporeflective line representing the photoreceptor layer, and the nerve fiber layer appearing with a hyperreflective area over the photoreceptor layer, and a very characteristic foveal depression which plays as a landmark for the macula during our OCT images. The normal OCT results, as we see here, the normal thickness is usually around 200 microns in the thickness, flat, there is no cysts, the retinal pigment epithelium in place, no spaces in between the retinal pigment epithelium and the retinal nerve fiber layer. This is the normal OCT result. We go first for OCT and its role in the epiretinal membranes. As we see in these images, the OCT and the epiretinal membrane, the first image, we can see the epiretinal membrane with which is very minimally visible clinically and on the OCT. But the important thing here in the early epiretinal membranes is the increase in the thickness of the macula. So you will find it passing more than 300 microns. It is so adherent to the macular area. So on the OCT we cannot detect any changes unless you can see this increase in the thickness of the macula. The inferior image, it shows us the visible bridging over the retinal folds, as you see now. This is one of the signs of the presence of a epiretinal membrane over the macula. On the other side, you can see the contractile increasing thickness with a macular edema. Once this membrane starts to make any contractions, it starts to make cystoid changes inside the retina, and this is appearing as epiretinal membrane with a cystoid macular edema. If it continues, it could form a pseudohole with increased thickness of the retinal pigment epithelium and verticalization of the border of the hole. This is a landmark for an epiretinal membrane with the pseudohole. The first image up, as you see it, is a normal macular cut of the OCT, while the inferior one on the left, it is a lamellar hole compared to a pseudohole with an increase in thickness of the macular area, verticalization of the border, and the presence of the photoreceptors over the retinal pigment epithelium just below the hole itself. So it's a pseudohole. This is an epiretinal membrane pre-surgery and post-surgery. So the OCT, it also plays a role in the judgment of the results of the surgery. Is it okay, or still it needs any interference by injecting the patients or anything. The first image, we see the epiretinal membrane. With post-surgery, we can see the presence of the foveal depression, which represents a very helpful, very good surgical interference for membrane peeling, and the macula returns to its normal position. While on the other, we can see there is no foveal depression, there is no landmark, so we can evaluate our vitrectomy. And in other images, we can see a residual edema that needs any more interference, like injecting the eye with any ways of injections like anti-VEGF or steroids injections later on. Another picture for the epiretinal membrane. As you can see here, there is a detached, partially detached posterior hyaloid, thickened, that forms a membrane, a traction membrane. This is a vitreomacular traction syndrome, making a certain form of cystoid macular edema. Before the OCT, we was not able to diagnose such cases because the interface between the vitreous and the macula, it was not so clear, as we can see it very clearly now with the OCT. We go for the macular hole. In fact, the OCT plays a very important role in diagnosing and clarifying the stages of the macular hole, as we will see now. The first image, we can see the fovea without a central yellow point, but there is a cystoid, a small cyst in the fovea as we see, and a partially detached posterior hyaloid. While in the other picture, we can start to see a central yellow point in the center. This is stage A with the cyst increasing in size. So this is stage 1A of the macular hole. If the condition continues, the foveal yellow point, it starts to be as a yellow ring, which is a stage 1B, because of the separation of the receptor, as you can see in the image here. If the macular hole continue on progressing, it starts to form an operculum, an opening in the roof of the cyst, and the operculum is attached to the posterior hyaloid, as you can see here. This is the stage 2 macular hole. I grouped all the stages of the macular hole in this image. In fact, as we see, there is a partially detached posterior hyaloid in the first image to the left. The inferior one, which shows the intrafoveal separation. The stage 1A, there is an impending macular hole with appearing of this cyst. If it continues, there is separation of the photoreceptors in stage 1B, and the opening of the roof of the cyst, which is stage 2, and then full thickness macular hole, stage 3, with complete deroofing of the cyst. Do you think that any macular or foveal cyst can develop in a formation of a macular hole? No, this is not right. A lot of macular cyst can recover by itself normally and disappears without making any macular hole, but it can make the episodes, as we have seen, to form a full thickness macular hole, or it can be detached rapidly and it makes a lamellar hole, as we can see here. So the cyst it's appearing, it could go either in a formation of a lamellar hole, or it will resolve spontaneously, or it form a full thickness macular hole at the end. In AMD, in fact, this is an image of a dry AMD, as you can see here, a confluent soft drusens with irregularities, as you see here in the retinal pigment epithelium, because of the elevation of the retinal pigment epithelium by the drusens in Bruch's membrane. So this is a characteristic appearance of the drusenoid changes in dry AMD. But still the macula is dry, there is no subretinal fluid, no element or traces of any choroidal neovascular membrane, as you see in the image here. Here another picture of a juxtafoveal choroidal neovascular membrane by fluorescein angiography. It's very clear it is a juxtafoveal, but is it really juxtafoveal or subfoveal? Let us to do the OCT and we'll see the image. Yes, it is very clear to be juxtafoveal, as it is clear here in the image, and you can see the membrane and the intraretinal fluid appearing in the juxtafoveal area. Not only the OCT can judge this, but it can evaluate also if our treatment is perfect or no. It is completely occluded here, and now with the OCT, it judged that there is no recurrence and no activity of the subfoveal, of juxtafoveal choroidal neovascular membrane, and the macula is totally dry, as you can see in this image, in fact. So the OCT, it helps also to evaluate that our treatment is perfect and no need to make any more interference. This another image that shows to us the OCT with a classic subfoveal choroidal neovascular membrane. As you can see here, the classic element of the choroidal neovascular membrane with the membranes bypassing the retinal pigment epithelium and the subretinal fluid and the small cystic spaces over inside the macula. And not only that, we can measure the thickness is 448 microns. So it is associated with cystoid changes, cystoid macular edema. This is a classic exudative AMD with a classic subfoveal choroidal neovascular membrane. Another appearance of subfoveal choroidal neovascular membrane associated with hemorrhages, as we see in the fundus and the fluorescein images. while with the OCT we can see an important cystoid macular edema which is not clear with the fundus and fluorescein images. So this is the advantage of the OCT to show us the spaces and the subretinal fluid and the presence or absence of any cystoid macular edema, and the type of this membrane, is it an occult membrane or classic membrane? It can be easily seen and diagnosed with the images of the OCT. We go to another category and importance of the use of OCT in our clinic is the retinal pigment epithelial rip. As you see here with the fundus picture, there is a part of the retinal pigment epithelium is denuded and enrolled, very clear with the fluorescein image, as we can see the area of hyperfluorescency. The OCT, it shows us very clearly as the area denuded by the retinal pigment epithelium is very highly hyperreflective, while the area with the enrolled retinal pigment epithelium, it makes a masking effect. So there is area of hyporeflectivity due to the enrollment of the retinal pigment epithelium over itself. So it helps us too much to diagnose the presence of or absence of any RPE rip post-injecting or post-intravitreal anti-VEGF injections or something. In CSR also, it helps us to diagnose the presence of any neurosensory detachment, but it doesn't localize clearly where is the exact site we can make our laser. It has to be added with the fluorescein angiography, but at least it will diagnose some cases which can be missed with the fluorescein angiography, as I show you now. The OCT and the CSR, this patient had a decreased vision in his right eye, which was not clear. Clinically, we can see there is a mild neurosensory detachment, which was not so clear with the fluorescein angiography. There is an RPE changes correlating with an old healed CSR in the left eye and also in the right eye in the late time. But the patient still complaining of decreased visual acuity. We did for him the OCT. As we see here in this in the OCT picture, we can see there is an increase in the thickness of the fovea, which was not clear with the fluorescein angiography image. Once we did the cuts over the macula, we can see these subretinal subfoveal fluid correlating with the presence of CSR. It is a resolving central serous chorioretinopathy. So we can explain to the patient why he still have this decreased vision, that it will go with time with absorption of this fluid, or it may need, if it would stay more than 2 months, it needs any interference by injecting this patient or by the use of micropulse laser. But at least we can follow this fluid if it is going in a good way or no. This is the advantage of OCT, in fact. Another image, the advantage of OCT to localize the exact site of leakage. As you can see it here, this is the cut over the area of the leakage or the leaking point. But this cut, it cannot tell you where is the exact site to make any laser. So if you are going to make any laser for extrafoveal leaking CSR, you are obliged to make the fluorescein angiography after diagnosing it with the OCT. The most important item for, or the things used for OCT, the macular edema. Macular edema, OCT, it makes a revolution in the diagnosis and management and follow-up for the macular edema, as we can see in the following slides. Macular edema, by definition, it's an increase in the retinal thickness in the macular zone. It is classified to be a focal macular edema or a diffuse. The diffuse can be either non-cystoid macular edema or a cystoid macular edema, as we'll see in the following slides. Focal diabetic macular edema, as it is clear here, this is a patient, a diabetic patient having a few dots of hemorrhages and hard exudates very close to the fovea, very clear in the OCT, and a very clear focal diabetic macular edema. With the fluorescein angiography, you can see these few microaneurysms, but it is leaking. the non-cystoid diffuse diabetic macular edema. With fluorescein angiography, the two pictures are close to each other. Which one makes edema? It was not clear. Is it really a leakage, or it is just staining in the late time of the fluorescein angiography? The OCT can answer you for this question. In the image on your left side, you can see there is no intraretinal fluid. It is just staining in the late time of the fluorescein angiography, while in the right eye, there is a leaking microaneurysms. If it is decreasing the vision, you can start interfering for the treatment of this patient. So the OCT can clarify it for you, especially in the non-cystoid diffuse macular edema. Before starting to talk about the cystoid macular edema, I would like to show you a slide that group the most important etiology of cystoid macular edema. As you see, the vascular lesion, and the most important is diabetic macular edema and hypertensive retinopathy. And the retinal vein occlusion, either central retinal vein occlusion or a branch retinal vein occlusion, and in idiopathic telangiectasias and Coats disease. These are the vascular lesions that makes cystoid macular edema. Surgical trauma like Irvine-Guss syndrome or post-RD surgeries. Inflammatory affections like retinal vasculitis, pars planitis, and posterior uveitis. In retinal dystrophies, we can face cystoid macular edema like in retinitis pigmentosa and Best disease. In vitro macular anomalies like in presence of epiretinal membrane making any traction over the macula, or the vitro macular traction syndromes. In exudative age-related macular degeneration, as we have seen, the associating cystoid macular edema in the presence of exudative AMD, in the presence of choroidal tumors, and in diffuse retinal epitheliopathy. We'll see a lot of these examples just now. In vascular lesions, like in diffuse diabetic macular edema, as it is very clear, we have in the fundus picture a lot of hemorrhages in both posterior poles, and in the late time of the angiogram, we can see a diffuse diabetic macular edema in both macula. It is considered as moderate to severe non-proliferative diabetic retinopathy with a diffuse diabetic macular edema. We do the OCT. It helps us to measure the thickness of the fovea. So we can see in the right eye it is over more than 500 microns, while in the left eye it is 457. So we can measure the thickness before any interference. So if we do any laser or any injection, we will see if this patient is improving or it needs more interference. These pictures show us if there is any neurosensory detachment. As we see here, there is a foveal central affection in both eyes. So it helps us to predict our way for treatment and the visual acuity of this patient later on. This is after injecting the patient by 2 intravitreal anti-VEGF. We see complete resolution of the macular edema, and the cuts of the macula is totally dry, and we continue following this patient by doing a laser treatment. Not only the diffuse diabetic macular edema, it is due just to microaneurysm, but it could be due to the presence of attractional membranes that makes the cystoid macular edema in the macula. So this is a tractional diabetic macular edema pre-vitrectomy. You can measure it and you see, and this is the image after doing the vitrectomy for this patient with membrane peeling, and the membrane is removed with the residual macular edema that needs to be more interference by injecting the patient later on, but at least the tractional element on the macula is removed. As you see, this is an image pre and post. So the OCT, it helps first to diagnose this case and to evaluate our treatment later on, and to help us to take the decision if it needs any interference for this eye or no. In hypertensive retinopathy, as in this case, we can see the cotton wool spots, hemorrhages, and important edema. Is it so serious or no? Let us to see the OCT. With the fluorescein angiography, we can see a very obvious diffuse macular edema due to hypertensive retinopathy, while the OCT, it shows a tremendous, extensive intraretinal fluid, especially in the left eye, which bypass even 800 microns. You see how much the fluid is inside the retina in both eyes, especially in the left eye. In vein occlusion also, as we see here in the right eye, he has engorged veins, intraretinal flame-shaped hemorrhages associated with an important edema. We did the fluorescein angiography. There is no signs of any ischemia with engorged dilated veins, intraretinal hemorrhages, and late cystoid macular edema in his right eye due to the central retinal vein occlusion. With the OCT, it helps us to measure the importance of this edema and how many microns it is elevated, and also the OCT play a role for the branch retinal vein occlusion, as you can see in this image, with a superior temporal small branch retinal vein occlusion leading to a late partial cystoid macular edema. Is it really important, this cystoid macular edema, or no? We'll see and measure about with the OCT. Yes, he has a partial cystoid macular edema with a large foveal cyst, as we see. This image, it helps us to take a decision to interfere for this patient by giving him intravitreal anti-VEGF. So here, as you see, this is the post-intravitreal anti-VEGF injection, and we can see how much the resolution of the partial cystoid macular edema with a residual very small cyst can be a matter of a few focal lasers over this leaking area. Surgical trauma that causes cystoid macular edema, as we see here, severe cystoid macular edema after Irvine-Guss syndrome. It is very clear with the fluorescein angiography, very important cystoid macular edema. Nowadays, in fact, I'm not doing any more fluorescein angiography for the search of the presence of cystoid macular edema post-cataract surgery or any surgery. We just do the OCT. It can help us without any injection for the patient. As we see, there is a large foveal cyst, and the foveal thickness is over 692 microns, as we see in the image here. In retinal dystrophies, as in retinitis pigmentosa, nowadays also we are not doing any more fluorescein angiography. It is clinically, you can see the typical appearance and the triad of the retinitis pigmentosa, and we are searching just for the presence of epiretinal membrane or cystoid macular edema. The OCT helps us too much to diagnose that. As you see, this is an example of retinitis pigmentosa, one known case, but there is no cystoid macular edema with fluorescein angiography. But let us to see with the OCT, there is increase in the foveal thickness in both eyes. So with the cuts here in the macula, we can see very clear the presence of a foveal cyst in both eyes, which was not appearing in the fluorescein angiography images. So the OCT is, as you can see here in this case, it is too much superior over the fluorescein angiography for the diagnosis of epiretinal membranes and cystoid macular edema in retinitis pigmentosa. And nowadays we are not doing any more fluorescein angiography for the cases of retinitis pigmentosa. We just take a fundus picture and we do a follow-up with with the OCT. In congenital retinoschisis, before we can see the cogwheel appearance of the fovea, and here, as we see in the fluorescein angiography, there is an area, it looks like an RPE changes, while with the OCT, it clarified to us, this is a magnified picture of the fundus with a cogwheel and the cystic spaces in the fovea. In fact, with the OCT, we found a very, very huge and important cystoid macular edema Congenital retinoschisis, it is a severe cystoid macular edema in the macula in both eyes. In vitro macular anomalies, as the presence of epiretinal membrane, it can lead to the formation of a cystoid macular edema by making traction over the macula. Is this traction is really making a cystoid macular edema or no? The OCT can answer to us this question. As we can see here, there's an epiretinal membrane increasing the thickness of the macular area with intraretinal cystoid spaces. In fact, this very interesting case, I would like to show it to you. This patient is a well-known patient having a macular hole, a full thickness macular hole, long time in his left eye, while in the right eye, he came to us complaining of decreased vision. This is a fundus picture. It was not clear for us why he got this decreased vision. We did a fluorescein angiography. He just have a very mild leakage in the fovea in his right eye. But it is not a telangiectatic changes. He is not diabetic at all. The cause for that was not clear with the fundus picture and the fluorescein image. And his vision decreased from 1.0 to 0.2. This is a magnified picture for the macula. There is an area of leakage just very close to the fovea in his right eye for no reason. We decided to do the OCT for this patient. Really, he has increase in the foveal thickness up to 425 microns. And let us to do the OCT. He has a vitreomacular traction syndrome and important cystoid macular edema with a partially thickened and detached posterior hyaloid rising the macular surface with a very important cystoid macular edema. This shows to us how much the importance of the use of the OCT for the search of the vitreomacular attractions, which was not clear clinically and even with the fundus and the fluorescein images. This is a group image show to us the importance of the OCT and superiority over the fluorescein angiography pictures. The role of OCT in glaucoma and glaucoma suspects and glaucoma case, it plays a crucial role, especially in the early diagnosis of glaucomatous patients. This is a normal optic disc. As we see here, the thickness should be over than 80 microns in the average retinal thickness in most of the cases, with the two humps very appearing in the superior and inferior quadrants of the optic nerve, and the very clear hyperreflectivity in the upper and the lower part of the upper and lower quadrants of the optic nerve as seen in the image. This is a normal appearance of the optic disc in a normal patient. This patient having an increased cupping in his left eye, while the left eye looks almost normal. Let us to see the OCT picture for that patient. The optic nerve thickness in the right eye is normal, while it is too much decreased in the left eye. It is 60 microns plus, so it is a moderate to severe glaucomatous change in the left eye, and there is a diminishing in the two humps in the curve for the left eye, as you see in the image, compared to the normal right eye. So this patient needs more evaluation for the visual field and a glaucoma department to start treating and following his eyes. Another example of a glaucoma suspect patient in his right eye, with just minimal decrease in the two humps and the thickness over 70, while in the left eye it is a considerable decrease in the two humps and the thickness in superior and inferior quadrants in his left eye, which is too much deteriorated in the left eye. Here, moderate glaucomatous change in both eyes with a typical change in the two humps in both optic nerves. It is a moderate glaucomatous change in both eyes. In fact, these patients have an advanced glaucomatous change in both eyes. as you see, the two humps is almost flat. The curve is flat. There is no hyperreflectivity, and the thickness is too much deteriorated in the superior and inferior quadrants of the optic nerve in both eyes. So, as a conclusion, OCT, giving us a quantitative measurement of macular edema, it's of great value in deciding necessity and appreciating the results of intravitreal injections, whatever intravitreal anti-VEGF, whatever the kind of it, or intravitreal triamcinolone, or any use of any intravitreal injection or even surgery. OCT plays a great role for assessment of vitreoretinal interface in epiretinal membrane, macular holes, and comparing with a great precision pre- and post-vitrectomy results. OCT differentiates with a high performance glaucoma suspect and glaucoma and glaucomatous stages. But we should keep in our mind that OCT do not replace fluorescein angiography, but adding a third dimension to it, allowing us to re-evaluate a lot of macular pathologies. OCT approaches us several steps forward for more understanding macular pathologies, serving the profit of our patients. Thank you.